Great. So can I screen share now? I think I have.
Okay, I'm going to stop sharing.
Yeah.
Fun. Oh, let's look at questions first.
Oh, okay, sure. Great.
I have 3 in the chat. So Marcus had a great sort of suggestion is to take notes or have a shared Google Doc. And I said, that's a fabulous idea. And we're recording as well. So Marcus then created a Google Doc so everyone can convene. Mina's taking notes.
Great.
Mira, I'm so sorry. Taking notes. Happy to share. Thanks. So that's all that's in the chat for me.
Okay.
Second, but a wonderful kind of coming together as a first block. Thank you all. But again, feel free to reach out to Dr. Stotland or Dr. Lager in what she talked about.
Thank you. Can everybody see my screen now?
Yes.
Okay, so this is the H&P that you were sent. Now, and I apologize, this is like, I did this in live stages too. I made some last minute additions to that. I didn't take anything out, so I can make this available. Kristen, I don't know what the best way is to make my few little additions to this H&P version available to them.
This, in that same folder where we had the original?
Yeah, I mean, I haven't uploaded it yet. Like, I literally, just as I was prepping for this morning, I was like, oh, we should talk about COVID. So like, I put in some stuff about COVID.
Well, you can just put it back in that folder.
Okay, I'll put it back in the folder and then we'll make it available to you. It's really, there's nothing in there that was like incorrect or anything. I just embellished it a little bit. And my highlights here I'll take out, but it's just a reminder to me to sort of what to focus on. So you guys have learned about general H&Ps for adult patients. And what I want to focus on today are what's different about the obstetrical history and physical. And it's a little confusing because you'll take the H&P, they're very similar whether you're seeing a patient in prenatal care in clinic versus on labor and delivery. There's overlap there, but it doesn't look exactly the same. And so you'll learn the nuance of that as you go through it, and I'll talk a little bit about that. But the general principles are similar about what are the important things in the history we need to know. And of course, if it's an established patient that we know well, who we've seen outpatient or we've seen multiple times in triage, and now she's getting admitted or they're getting admitted for labor, you know, then we won't have to take as much of a history because we already are familiar with the patient. So for the first thing, the age, the G's and P's. So I want you to review your G's and P's. I know this is something we harped on a lot in life stages. Review for yourself the TPAL nomenclature. So T is term deliveries, and P is preterm deliveries. A is abortions, which includes miscarriages and elective abortions, including ectopics, and L is living children. So as you might remember too, I don't know how much we got into this, but if somebody has had a twin birth, that's just one G and one P. So if they were term twins, you know, say 38 weeks, and that's the only birth that they had, they'd be a G1P and then 1, 0, 0, and then the L would be 2. So the way you find out that they had twins is because living children will be more than the P, if that makes sense. I've seen even residents and others not do it this way, but this is the, I think, official way to do TPAL is that multiple births, like twins, are just considered one birth, but you have hopefully you have 2 living children. So, and then the HPI. So let's say you're asked to see a patient in triage for labor. You want to ask about, you know, what are they feeling or experiencing in terms of labor, contractions, bleeding, leakage of fluid, preeclampsia symptoms. People remember what those are? So headache, abdominal pain, especially upper abdominal pain, and visual changes. How is the baby moving? It's usually we ask. They feel the baby kicking and moving like normal. Decreased fetal movement can be for a lot of reasons. It can be because the fetus is starting to not get adequate oxygenation because of a variety of complications, or it can just be because the bag of water is broken and the fetus has less space to move in, but that can be an important part of the history. And sometimes it's what brought the patient into triage is that they're not feeling the baby move as much. For contractions, you want to ask how long have they been going on? When did they start? Have they been timing them? Can they talk through them? Can they sleep through them? Do they have to sort of huff and puff and breathe through them? Are they getting stronger? If the patient notes bleeding, when did that start? You know, was it a spot on a pad or on underwear? Or was it gushing? Were there clots? And then, you know, again, any abdominal pain, particularly like in between contractions. And then if they think they may have been leaking fluid, so you say, are you leaking any fluid out of the vagina, different than your sort of baseline discharge, usual discharge that you would have, any water coming out, then yes. Then when did you first notice that? How much? What was the color? And please jump in if there are any questions as I go. Current pregnancy, you can review this on your own as just, are there any things that came up during the prenatal care that we should know about? This is really important, what I've highlighted here, past OB history. This is one of the most important things that I think sometimes learners will leave out initially as they're getting used to the OB H&P, but it's one of the most important things. Or, you know, interns, junior residents, when they're giving presentation, will leave out and I'll be like, okay, please tell me, you know, they'll say she's G3, P1, or, you know, G4, P3, and then go on with what's going on with this pregnancy. But I really need to know what happened with those other births, particularly if they were C-sections, right? Because a previous C-section can really complicate, not always, but it certainly impacts how we, what types of treatments we offer, how we evaluate the patient, et cetera. So it's really, really important to know about what happened with each prior pregnancy, especially, you know, if somebody's at term, I don't really actually need to know a lot of details about their prior miscarriages or abortions. What I need to know about are their other births, you know, what happened in those. So what was the date of delivery? You just want to know how long it's been since they last gave birth, what gestational age were those births. Ideally, you want to express those in weeks, not months, but the patients will often only know in months, right? So they'll say, I had a baby at 7.5 months. And really, when I hear that, I'm like, okay, what I'll often do to try to suss that out is like, be like, how much did the baby weigh? And did the baby have to stay in the NICU? Because 7 months, 8 months, you know, I don't know if that's a preemie or, you know, a lot of times it doesn't translate into medical gestational weeks. So I have to either try to get the records, or you can get a lot of information just by asking, you know, they might say, oh, my baby was born a little premature, but in their mind, that's just because it was like a week before the due date. And then then you find out the baby was 7.5 pounds and went home 2 days later. That was not a preemie baby, you know, at least clinically. So that can really help sort of determine when the patient doesn't know how many gestational weeks the birth was. So the type of delivery is really key. Did they have a spontaneous vaginal? Were they assisted with vacuum and forceps, or did they have a C-section? Any other complications they had, the birth weight of the babies. If they had a prior C-section for each one, what was the reason? As far as they know, a lot of times they're not totally sure why the C-section was done, which is highly unfortunate. And it's, you know, not always, but often a sign of not great care when at their prior birth. And were they told for some reason that it's dangerous for them to labor again? It's pretty rare to have patients who are told that, especially that are told that for a legitimate reason, but it does happen. So what we're really thinking about there is if somebody's had what's called a classical C-section, where the incision was made up into the contracting active muscular part of the uterus, because those patients are at a much higher risk of a uterine rupture if they labor after a C-section that was a classical, that was in the contracting part of the uterus. And so if we do a C-section, a classical C-section, and there are limited indications for that, but we do still sometimes have to do them, we will tell the patient multiple times after the delivery, ideally, you know, we don't recommend you have a labor in the future. If you get pregnant again, you know, please tell your providers that you had this type of C-section and that you really should have a repeat C-section. And that's what we recommend. So if they were told something like that, we really need to know. In terms of asking about miscarriages and abortions, again, I don't usually find that's very relevant in the moment of someone who's now full term or close to term, because, you know, yes, a miscarriage is a risk factor for a future miscarriage, but if they've already gotten to 38 weeks, it's not really, you know, that impactful. But if it is part of the full history, but this is an important thing, to not assume that their partner or family are aware of actually any of their past birth history. So to the degree that this is often just something we struggle with on labor and delivery, because patients want their partner and family in the room as much as possible, but there's parts of the history that are best taken in private. So this is often a balancing act to say, oh, we'd like to take this part of the history in private. Is it okay if we have everyone step out? And if they don't want them to step out, we don't force that. And then you just do the best you can. And they will tell you what they feel comfortable telling you. I'll get to how COVID impacts that, I guess, at the end. GYN history, you can review that on your own. And the truth is, most of the GYN history is not super relevant to labor, but some of it can be, especially in prenatal care. Like it says, certain procedures on the cervix can cause increased risk of preterm birth, although most of the time it really doesn't change the management very much. Really important, the past medical history and the past surgical history. So if the patient has a history of diabetes, hypertension, asthma, seizure disorder, depression, all of those can have impacts on pregnancy, thyroid disease. So just anything, any chronic medical conditions that you've seen a doctor for, that you take medication for. Actually, I don't think this list actually has a list for medications, so we should add that as well. What medications are you taking? Drugs and allergies, that's like any other patient. So in terms of social history, one of the things I added here was really who's their support network? Who do they want to be present at the birth? Now here's where I got into some of the COVID considerations, because it's really been pretty devastating for birthing people and families, on top of everything else, that COVID has restricted visitors at hospitals. Now, when the pandemic first occurred, they weren't allowing visitors for anybody, no matter what, which was just really horrendous for birthing people. And then they sort of started a compassionate exception category at most hospitals, where, you know, pediatric patients, some end-of-life patients, and birthing people could have limited support people with them. So currently at San Francisco General, for example, patients can bring one partner with them, one person to them. Now, we had a more liberal policy than some hospitals about doulas, also allowing doulas, particularly for our patients who are most vulnerable, allowing them to have, we have volunteer doulas, and we have, there are some particular doula programs that are for certain communities of color and other things, and they're really providing a critical service. So we fought to really have the doulas be allowed. I just saw an alert. This is something, COVID stuff is changing day by day. So it's just really important to have good communication with your team about what the protocols are. But for example, I just got an email this morning that looked like they were now not letting us have the doulas at SFGH because the COVID rates are so high in the community. But it's just going to change day by day and depend on the hospital. In terms of what happens when patients come in for care with COVID, like, for example, at SFGH, patients are screened when they come in the door to triage either for labor or any other problem for COVID symptoms and COVID exposures. And generally speaking, students are not supposed to see any patient that comes in with COVID symptoms until they've tested negative, or a patient who's known COVID positive. And in fact, generally speaking, we don't have any trainees, including residents, seeing those patients except for surgical procedures and things where we really need the whole team. You know, again, this is where it's going to be really important to talk to your team at your particular site on the first day about how are you handling COVID screening? How does that affect which patients students can see? So we don't want to happen is you to go in to see a triage patient and find out, oh, they're coming in for cough and fever. That should not be a patient that you're seeing primarily. And so we have pretty strict protocols, like the attending at SFGH sees all the patients who have like flu, or the attending midwife or attending doctor sees any patients who come in with COVID symptoms or are known COVID positive. We don't even have the residents see them primarily. And usually that screening, those questions are asked by the nurse when they first arrive. And then the nice thing about labor and delivery, although testing has been a little more restricted because they've run lower on test kits, I think, you know, in our region, but like when patients are admitted to labor and delivery, they get a rapid COVID test. And so usually within 2 hours of them arriving on the unit, whether they have symptoms or not, if they're getting admitted for labor, they get a rapid COVID test. And so that really helps us to, you know, involve more learners in their care, et cetera. But if for some reason you know, occasionally this happens where a patient doesn't reveal that they have COVID symptoms until like well into their care, like, you know, they've already been seen by one provider, and then a student could potentially go in and talk to the patient, and then the patient says, oh yeah, you know, I have lost my sense of taste and smell. You know, if you detect any COVID symptoms when you're interviewing a patient, I would politely excuse yourself immediately and then let your team know that you're concerned the patient could have COVID symptoms, and so it's not appropriate for you to see that patient. I hope that doesn't happen, but if it does, let us know. Any questions about COVID stuff? No, okay. Sorry, allergy. So physical exam for the OB patient. Of course, always start with vital signs. And fetal heart tones, another thing I added to this H&P at the end is there's a little link to an APGO video, because in life stages, we don't really teach you about evaluating fetal heart tones or fetal heart rate tracings. We don't expect third-year students to know how to interpret fetal heart rate tracings, but it is something that you learn in the rotation. However, if you just read a little bit or watch a video before, you know, or in the first week of a rotation, it will really help you understand what's going on at rounds. It will help you, you know, complete these H&Ps in a thorough way. We don't expect you to be an expert or really know detailed interpretation, but I think it's important to know what are the components of a fetal heart rate evaluation, which is the baseline heart rate, which the normal is like between 100 and 160 is normal, and then higher than that is tachycardia, lower is bradycardia. And this is all in the video at the bottom, and there's other resources you'll begin as well, but I just thought that video might be fun to just watch. Those videos are a little bit dated and a little bit tacky, but the content is correct generally in them, so they're handy. Variability, when I say dated, I just mean like the style I don't like, but the content is okay. The variability, so that's how much the fetal heart rate tracing squiggles up and down, or absent variability would be like a straight pencil line. And then marked variability would be almost like a, you know, just like a zigzag big squiggle. So that, and variability, normal moderate variability is a sign that the fetus has an intact CNS and is getting adequate oxygenation. And so that's a very good sign of fetal well-being, as we call it. And then presence of accelerations or decelerations, which again, you can read about, watch a video. We don't expect you to be an expert, particularly in the first week, but just to be familiar with some of these terms. And then another so fetal heart rate evaluation and the contraction pattern is sort of part of the vital signs of an OB H&P, okay? So, and then the contraction pattern, also referred to as a TOCO, referring to contractions. And so how frequent are the contractions on the contraction monitor? And then an H&P would include the physical exam would include a heart and lung exam for most patients. Breast exam you would not be doing for like an L&D admission, only for say a first prenatal visit where they haven't had a full H&P, you know, they haven't had a well person exam in a long time. You might do a breast exam then, and you might do it in a postpartum patient who's presenting with breast symptoms, but it's not a routine admission type of thing. But you would do an abdominal exam, mostly checking for tenderness and Leopold's maneuvers, which you can, again, you'll learn on the rotation, but it's good to read about just sort of how to palpate for the position of the fetus in the uterus, and also to get a guesstimate of how big the fetus is, which is sort of a fun guessing contest on labor and delivery because it's highly inaccurate, but people like to try to outdo each other in guessing correctly. And then in some cases, there'll be a speculum exam indicated, most likely if the patient is complaining of bleeding or leakage of fluid. If they're there for a prenatal visit and they're due for a pap smear or they need STD screening, STI screening, that may also indicate a speculum exam. I try to avoid speculum exams in pregnancy if they're not absolutely necessary, but sometimes they are. And I try to avoid them just because they're more uncomfortable than not during pregnancy. Okay, and then if there isn't concern for rupture of membranes, but we want to know if the person's cervix is dilated, then that's called a cervical exam, a digital cervical exam, digital meaning our fingers. And I would say in general, students are not doing a lot of labor cervical exams. It's a skill that it takes a lot of repetition to really know what you're feeling. It can be pretty uncomfortable for patients. So my feeling is that, you know, if you go into a field where you need to learn that, if you go into OB or family medicine, you're going to be doing lots and lots of cervical exams in your first year of residency. And if you're not going into one of those fields, you're not going to be able to master that skill in your third year rotation anyway. So it's interesting to do. And if you're particularly interested in OB care, there may be opportunities for you to do a vaginal exam. For example, if a patient has an epidural and is completely, they often can't feel the exam at all and are very comfortable with having a learner do an extra exam with permission, with discussion. So in some cases, it can be appropriate for students to do those exams, but most of the time, those exams are not done by students. And I'm happy to take any questions on that. And just review, this is something we covered a lot in life stages, but what are the components of the cervical exam in labor? So dilation, effacement, station, review those, and you can review your life stages materials. It's relevant to this. And then usually an ultrasound is done to confirm the position of the fetus as well, that they're head down. And let's see, how are we doing on time? Any questions? I feel like I'm talking so much. People have any comments or questions? No. I think you can review this on your own. There's like a sample sort of components. This is a good thing to sort of keep in your pocket or in your device with you when you are on the rotation, so that you can quickly have a cheat sheet of what are the key components of the H&P. Do I have chats that I've missed?
No, but there's many thanks for this information.
I'm sorry?
But there is thanks for this information. So I think everyone's
great. No, I see a question about, would you explicitly state the conditions that you were concerned about to make sure it's not missed? Yeah, that's a really good question. I think different providers have different approaches to this. So, I mean, if I have a particular concern, I don't necessarily go through, like when I'm taking past medical history, I personally don't. It depends on how forthcoming the patient is and if I feel like they might need some prompting just from a gestalt. But I would say I don't routinely just sort of say asthma, diabetes, hypertension. But like if I get a sense they're not sure what I mean by medical problems, then I might suggest some of those to sort of help them understand. But I will say for the OB history, we often do, I think it is a good idea to just sort of always ask, like these 3 things. Are you having contractions? Are you having bleeding? Are you leaking fluid? It's 4 things. Are you having contractions? Are you having bleeding? Are you leaking fluid? Is the baby moving? Those 4 are sort of like the universal questions. And then preeclampsia symptoms, those you should just, you know, memorize and have them, you know, again, I don't really spend a lot of time asking about those if the patient's blood pressure is totally normal and they say they're feeling fine, but it's never wrong to ask, are you having any headache, visual changes, abdominal pain, which are sort of the key preeclampsia symptoms. So I think having a low threshold to ask about those things is important. And surgeries, again, like it's really important to know, particularly if a patient has had abdominal surgery in the past, because, you know, the C-section rates vary a lot, and that's a topic for another day. But, you know, the risk of having a C-section isn't, you know, all comers who come in labor is, you know, at the lowest C-section rates probably, you know, in the state are 15% or 20%. So it's not a negligible risk. And many hospitals, it's much higher. Nationally, it's about 30% of all comers in labor will have a C-section. So, or all comers to full-term birth will have a C-section. So it's very important to know if you're going to be operating on somebody's abdomen, what scar tissue they may have, what issues you may encounter on entering the abdomen. So it's really important to know. One of the things I added to this H&P was also asking about past anesthesia complications, which different hospitals have different approaches. Some don't have in-house 24/7 anesthesia, and anesthesiologists have to be called in for labor epidurals or C-sections at Mission Bay and at SFGH. And most of the major hospitals in the city, we have 24/7 in-house anesthesia. And some hospitals require every patient to have an evaluation by an anesthesiologist when they get admitted to labor and delivery. But that's actually very controversial, especially at our hospital. Particularly our midwives really feel strongly that having an anesthesiologist evaluate an otherwise healthy labor patient can be problematic, because a lot of, particularly the patients who seek out midwifery care, really don't want anesthesia unless it's an emergency, and really don't want to be in that frame of mind thinking about what could go wrong when most likely it won't. But that being said, some hospitals will have every patient seen by an anesthesiologist, just in case they end up needing anesthesia of some kind. I think that was the only question. Just pull the chat. I don't know if it's okay to finish a little early or if people have other questions. I can stop screen sharing.
Yeah, it's a-okay to finish early if there are no other questions, if you got through your presentation and all that good stuff.
Yeah.
I have a question.
Please.
And so I imagine that like being, well, I've never like personally been in like labor and deliveries. I'm like wondering how can students know where they're supposed to be and like what they should be doing, especially if maybe it's their first time seeing a live birth.
You mean like in the room, like when we're in a labor room? Yeah, that's a great question. I mean, ideally, you have a discussion with your team before, both on the first day and sort of ongoing back and forth when you're getting ready to go in a room. But I hear from students every now and then that they're just sort of pulled into a room. Like a nurse will say, go into room 4. They want you in room 4 for birth. We try at SFGH to have the policy of like, if a learner is going to come in for a birth, the patients ask permission, then you're brought in and get to introduce yourself to the patient, like not in an urgent moment. Better for everyone that way. But sometimes it will happen that, let's say a patient comes in, it's like our third baby, it's going really fast, and the provider says, oh, can I bring my student in? They say yes, so they shout out to, it's like, send Emily in right now. And so you may be sort of, and they may have asked permission, but it may be kind of like there wasn't time to sort of plan beforehand. So in that case, hopefully the provider is going to give you very specific directions. Like, I want you to stand here, put your hands here, put your gown on, you know. And if they're not doing that, then I would presume in that case that you're there as sort of a support person. And then I would introduce myself to the patient and stand at her shoulder, honestly, and like be a coach and be supportive. And then your provider, your teacher will ask you to come around and like help with the procedure if that's the plan. So, but I wouldn't like start, you know, doing birth maneuvers unless you had a pre-existing discussion with your proctor, with, you know, that was what you were going to do. I mean, it's perfectly okay to ask, to say, you know, is it okay if I participate in this birth? You know, like, but they should be very explicit with you about what your role is, even if you're sort of called in last minute into a room. If you're called in last minute, like sometimes miscommunications happen, like the nurse will tell you to go in there, hopefully not at my hospital, but the nurse will tell you to go in there and the providers didn't necessarily know you were coming in. And so then again, I would just say, introduce myself to the patient, figure out if she needs, you know, the patient, if they need support from you, you know, try to, you know, provide, you know, emotional support, and that's it. And again, with COVID, you know, it's tricky. I mean, we're trying to reduce the number of people in each kind of clinical setting within reason, right? Again, like the nice thing about labor and delivery, at least at some of our hospitals, is they're getting rapid testing. So a lot of these patients will be known at least to have a negative rapid test prior to you coming in to care. So you can feel a little bit better about, you know, providing that close support, because you can't really do that from 6 feet away, you know. But that's a great question. Any follow-up on that? I don't know if I answered your question.
Oh yeah, that was really helpful. I'm wondering what kind of support, if we are maybe designating ourselves to that support person, like what kind of things that we can do in the moment to help.
Yeah, I would, you know, I would ask, you know, I'd ask them, like, how can I help you? And, you know, can I, you know, get you water? Can I rub your back? A lot of times, you know, like, and it depends, you're going to see such a variety depending on your site and everything else in sort of how much support patients need. But like in the past, pre-COVID, you would go into a labor room and there might be 5 or 6 people in there, you know, patient support network, you know, doing things for them. And now it's one, right? Most of the time. And their support person may not be, some of them are really equipped emotionally and otherwise to really provide that support, and some aren't. So I think sometimes you can really be that sort of, that rock for that person to just, even just being there holding their hand or just being by their side. I mean, there was actually a study that was done about continuous labor support. I think it was done, apologize, I can't remember what country it was. I think it was in South America, maybe in Brazil, at a hospital that was serving mainly low-income patients. And a lot of them came in and didn't have any partner with them. And they did this randomized study where they just had a person come and sit with them during labor, because the nurses can't really sit and be just like a continuous support person. They have all these other duties, you know, charting, measuring, getting medicine, you know. So like just having somebody sit with you and be with you led to better birth outcomes, fewer C-sections, fewer birth complications. So like just having somebody with you who is like dedicated to just your support is beneficial. But, you know, asking them, you know, is there something I can do to make you feel more comfortable? You know, or if they do have their partner with them or a doula, you can ask them, that person, how you can be helpful. Or ask the nurse. The nurse is a great resource. The nurse has often been with the patient for several hours and has been like struggling to try to be that support person while they're doing all this other stuff. So a lot of times you, again, this is if you're not being asked to like do hands-on.
Thank you, that's helpful.
Again, like often you'll be pulled in before the baby's coming out. And so you'll have a chance to do both roles, right? You can be a support person during the earlier part of labor. And then as the baby's emerging, you can often participate in the birth.
Well, if no other questions, many thanks to Dr. Stotland. Thank you again. That was wonderful. This was, of course, recorded, so we'll put this in the box when the entire program is done. So for right this second, I'm going to stop the recording.